All right. Good afternoon, everyone. Welcome to the Substance Use Response Group, SURG Prevention Subcommittee meeting. There's this one this week and one next week. Don't get confused. We had a lot of business to take care of from over the summer and really glad you all could join us today. I am going to start with agenda item number 1, which is a call to order. Ms. Rodriguez, do you mind establishing quorum for us?
Senator Fabian Doñate.
Here.
Jessica Johnson.
Present.
Debbie Nadler.
Present.
Angela Nichols.
Present.
And Eric Schoen.
I'm here. Hello, everybody.
Great, Chair Johnson, we do have a quorum with all members in attendance.
Fantastic. Thank you. And if you're just joining and not currently speaking, if you could kindly mute your Zoom microphone, that would be very helpful for background noise. Our next item is agenda item number 2, which is public comment. Ms. Rodriguez, can I turn it over to you again to help us be oriented for public comment today?
Yes, so I will just read the instructions on the screen. So public comment will be received via Zoom by raising your hand or unmuting yourself. When asked for public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public. If any, in discussion of those comments, no action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241020. If you are dialing in from a telephone and wish to provide public comment, please dial 253-205-0468. And when prompted, enter the meeting ID, which is 825-0031-7472. And then please press *6 so the host can prompt you to unmute.
Wonderful. Thank you, Ms. Rodriguez. Do we have anyone for public comment?
So far, Chair Johnson, I see Debbie Nadler as the only person with their hand raised.
Thanks. Ms. Nadler?
Hi, everyone. I just wanted to remind you that this Saturday, August 31st, is International Overdose Awareness Day. And 10 High and Moms Against Drugs are doing an event at the Vegas sign. It will be turned purple. And actually, they're going to turn it purple for 6 days for us. So it's really going to be Wednesday night through Tuesday. So that's a good thing. So if anybody wants to come at 7:30 Saturday night, all are welcome. Thank you.
Thank you, Ms. Nadler. Do I have anybody else for public comment?
Chair Johnson, I don't see anyone with their hand raised or otherwise indicating they would like to provide public comment.
Wonderful. All right. Thank you, Ms. Rodriguez. We'll close agenda item number 2 and move on to agenda item number 3, which is a review and approve the minutes from our August 7th, 2024 Prevention Subcommittee meeting. Thank you to staff for getting the meeting minutes out to everyone for review in advance of the meeting. If folks have had a chance to review, I'll entertain a motion to approve the minutes from the August 7th meeting.
So moved, Chair Johnson. Eric Schoen for the record.
Thank you, Vice Chair Schoen. Do I have a second?
Debbie Nadler for the record, a second.
Thank you, Ms. Nadler. All in favor say aye.
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 Aye. Any opposition? And any abstentions? The minutes have been approved from August 7th. All right, we'll move on to agenda item number 4. We have with us Jay Colbelt-Clausel from the Nevada Community Health Workers Association and Wendy Madsen from Healthy Communities Coalition, who will be giving us a long overdue presentation on community health workers to our subcommittee, which is related to several recommendations. Emma, is there any guidance for the presenters before we turn the floor over?
I believed we had discussed about a 10-minute presentation with time for questions from the subcommittee members following the presentation. And Jay and Wendy, I did have your slides from when you originally scheduled to present back in May. I have those included. Would you like me to forward those slides, or do you have your own slides that you want to share?
I have an updated version, if I may.
Okay, great. I will stop sharing and you can bring up yours.
Perfect. Hello, so Jay Colbert Clausel for the record. We'll get all the buttons pushed here. All right, did that share the screen or is it still thinking about it?
I think you're on your way. There you go. I can see that now on my
Oh,
end.
perfect. Always a good sign when that happens. All right, and we'll get the ugly spreadsheet out of the way. Or that wasn't a spreadsheet, Word document. Yeah, so I'm with the Community Health Workers Association. I joined in 2021. I wasn't able to check in with Wendy if she wanted to assist today. So if Wendy, if you're on the line, I will welcome you to hop in at any time. And I have my screens all set up. I'd also like to introduce Cody Wagner, who's the interim director for the Community Health Worker Association. So especially as the next session is coming, if you don't already know Cody, Cody has been with the community or the Healthy Communities Coalition for about 6.5 years, was one of the very first trainers for community health workers in the state, and is currently in that role and helping with this transition time with the Community Health Workers Association. So,
Hi, everyone. Thanks, Jay.
Thanks so much, Cody. All right, now the buttons are working. Perfect. So I think most people in this room are pretty savvy and are aware of the definition of a community health worker. This will be in your materials if you want to read through the definition. Multiple federal agencies do have different definitions for community health workers, but the APA definition is the most broadly accepted, and CMS accepts this definition. So it's good. There are a few outlier grants that try to kind of redefine things or simplify things, but this very open definition is recognized by CMS and being used for Medicare and Medicaid at this time. Nevada has recently joined the Core 3 project. Originally, Nevada had its own set of standards about what community health work education was. They were very close. They both had a lot of similar bullet points, and we do have detailed resources on those Core 3 competencies that are more generally accepted across the country now. As of August 21st, we've had 2,679 people sign up for our class. You can see they're students from every county. The youngest was 17, the oldest was 96. Unfortunately, the 96-year-old did not graduate, but a lot of people participate in the training, even if they don't want to make it some full formal career. It's more that they just want to be able to serve their community better, and so they're going to come to some of the workshops, and maybe they're not going to turn in all their homework. But we welcome that. We have a good representation from rural communities, from urban communities, large uptake in Clark County over the last couple of years because we've had more scholarships to offer down there. And then also there aren't quite as many classes down there, I think, which is one reason why people do our online class. You can see for education, it's also across the board. We have people who haven't completed their high school diploma, and we have people with a doctorate. So on average, you're landing somewhere has taken a few college classes, but not really any formal education to go out and do public health work. And I didn't speak to the diversity of the student body for both ethnic and racial demographics as well. Nevada is a very diverse state. We're one of only, I think, 5 states with more than 10% Asian community in the state. It's a very underserved population, especially regarding health access and blood pressure control and things. So that's something that's been improving, and it is also our weakest recruitment area for students. We do have I'll hop back just for a second. So about 30% of our students do come from the Hispanic community, And recently, African-American students have really increased. So if I were to look at a current quarter, it's also around 30%, even though Nevada is only about 8%. Oh, my apologies. If anyone needed to ask a question, feel free to hop in there. Now for these job descriptions, we really like to give an overview of what a CHW actually does when they are out in the community. So we have a database with just example job descriptions for somebody who might be interested in hiring a community health worker. These are a lot of the core competencies, but then a specific job might be a little bit different. So in our food pantries, we have that community-based setting, community health worker. They're really working on that community engagement, doing some workshops, helping people with resources. Like somebody comes for their basic sustenance or needs, and if we are able to do a little bit of documentation, we can access healthier food from the food bank to provide that. And that makes like the whole pantry kind of more like I forget the term, Wendy, medical nutritional pantry, and we were able to give healthier food out. So this is our Dayton facility. But did you want to put it out that term?
Yeah, well, we work with partners that we do an RX pantry or prescription pantry. So, so Food Bank of Northern Nevada works with physicians, and they refer to the pantries, and a CHW, welcomes that individual and gets them directed to the healthiest choices available within the pantries.
Perfect. And when someone comes in, often they're coming because they're hungry or they want to socialize, and, bigger needs come up. They have a grandson who's just exiting the justice system, or, they haven't done anything about the fact that they have high blood pressure. And so we don't have like a medical facility, but we're able to assist with them getting into those higher levels of care, or we might even have a CHW who works in those specific areas who can assist. And so that the food pantries were at, for the first few years, almost all of the CHWs in the state. I guess we'll start because the prevention coalitions really took charge and have had community health workers over the, I guess since about 2014, 2015. And then that final piece there, that data collection, we're going to get into that a little bit more because I'm hoping y'all can get in the weeds with me. So we have mental health support. So as of March 1st, it is now billable for a social worker or an MFT, a licensed MFT, to supervise a community health worker team. There is a little bit of ambiguity in the regulation on what those services are. So that's something that I think Medicaid's still exploring, and that they were going to do a workshop to add an additional clarification. What they were trying to ensure was that somebody wasn't doing peer support services and billing as a CHW, which doesn't make any sense. And so it makes sense that they weren't able to get that part exactly locked down because it is a little more complicated. But we want those community health workers to be able to assist with those initial assessments. They're not a licensed counselor, but then they can refer people to a counselor. Or if somebody they might have assessed somebody and identify a substance misuse situation going on, they don't diagnose them, but they can refer them to those higher levels of care. So that's where we're missing a tiny bit of clarity in the code to really see that take off. And so we don't see many CHWs working under community health or under social workers and other behavioral health professionals yet, even though it is allowable. We have CHWs in a clinic. Nevada was kind of backwards to the rest of the country. Most of the country had CHWs working under social workers. And in Nevada, we really had a lot of evidence for community health workers helping with cancer patients and other chronic diseases. So that is what the state began with and has rolled out to the federally qualified health centers, to the tribal clinics. It's in fee for service and other medical settings. So we have those community health workers out there. It's between 20 and 30% of all the community health workers we've surveyed. With home visiting and childcare centers, that's another area where there's a lot of grant opportunities and partnerships, like with the Children's Cabinet, where we're educating a lot of people who are working with families. Doulas often will dual certify because the doula services might not be as long-term as the services that their clients need. And so they're exploring the community health worker path as well. And you'll notice a running theme of some of that data in there. So here we have a few stats for CHWs who are doing the type of service that this committee focuses on. I last updated this in May before our last meeting, but the numbers are roughly the same. And you can see there's a general trend to more community health workers being involved in prevention, substance misuse, and behavioral health services. There are some demographic differences. We see more Native American, Hawaiian, Asian, and African American CHWs participate in these services compared to white or Hispanic CHWs. So just an interesting observation there. And then we also collect some information on the number of clients. So many CHWs work with between as low as 35 and as high as 500 clients. In some of those clinical settings is where you're going to see those really high numbers, and you have to be, pretty well organized. And their definition of what a community CHW encounter is might be different according to the different organizations. But on average, you're running at about 105 active clients for one CHW, working about an hour and a half per month with each client. The Medicaid rules allow for up to 12 hours. And then if you want to go over that, you can get a prior auth for a client with a higher need. All right, we've had these three main bills for community health workers in the state. So I think most of you are going to be pretty familiar with this text or worked on it personally, as I recall. And so really good to see. If there are questions about that, we can come back to that one. Something I wanted to explore, and this is where it's a little bit in the weeds today, is with the administrative code. So the Nevada Administrative Code wrote about CHWs in 2017. The very first community health worker bill was about community health worker pools. And it wasn't wrong, but it was just too early. The market wasn't ready for that. And so now that we have a lot more community health workers in the state, the Nevada Administrative Code, or another path as your expertise leads, could be a path to see better, here, I'll get off the boring slide, see better access to care-based or community-based organizations that can't currently bill with the current system, and then kind of clean up some of these other situations. So just going down through the bullets, without citing all the numbers and everything, I do have an annotated Word document that I shared with Emma and can be shared with all of you on just some thoughts on these different bullet points. But the Nevada Administrative Code has a CHW administrator write a service plan for each client. And that community health worker pool administrator has to do that plan. They have to do the initial assessment with each client. So that was a totally different business model, one that I think is out of date. So something for you all to think about or explore. A service plan is also confusing because it's not a case plan. A case plan is something that requires a licensed professional to do with the state. And so it's kind of this ambiguous middle ground that we probably don't want to exist in code. And so just to point that out, the community health worker administrator should be designing and making sure that the assessments are appropriate for their teams, but they probably shouldn't have to do every single one of them, and it shouldn't look like a case plan because it's not a case plan. The reporting guidance in the Nevada Administrative Code is also really helpful, and I think a strength of having community health workers on the team is how are we going to collect more data, deal with these social determinants of health, get all of that coordination to occur. And there's actually a lot of work that's already been done by the State Board of Health on what that guidance or that reporting guidance should look like. And it's written in the administrative code. The administrative code also recognizes the full role of a community health worker, even though not everything's billable. And so that's something we want billers to understand is it's a community health worker can do certain things, like they can transport a client, but that's not billable. So it's not that it's not allowed, it's just not billable. And so some of those things, another one of them is that community outreach. Like if you're tabling in an event, you can't bill Medicaid for tabling in an event, but it's still an allowable activity. And if you have a good business plan and you're really managing your clients and your billable activities, then you do have time for the whole picture of a community health worker. I already kind of spoke to this, but I think there is market demand for CHWs in these settings more. I believe that there are organizations that would administer a community health worker pool in both the North, South, and rural areas at this point. And so although it's kind of just sat on the books since 2017, it might be the time to get this part of the administrative code and the administrative side of it squared away. I don't know if that would require any legislation. You could all look into that and see what your goals are and make that determination. And then we already spoke a little bit to the client screening. So that's the main thing I have to present for you today. I don't know if Wendy, if you have any final thoughts before we open it up to questions.
I think it all looks great. I'm just here to listen in and learn as well. Thanks, Jay.
But it's just oh, it's not on.
Okay.
It just that's the yeah. I know it's loud.
Perfect. And how formal is the questioning process? Do we need to do that through the chair, or how would you like to open it up for questions?
This is Emma Rodriguez for the record. I believe Chair Johnson is having some technical issues. I'm not sure if she's able to come off mute. Let me try to see if I can. So Chair, I'm gonna ask to unmute and see if that works. Okay, I think she's having trouble. So I believe the next thing we do is go to Vice Chair Schoen to handle that.
I think this is just part of her plan to eventually have me take over chair duties. This is becoming a pattern. So good afternoon, everybody. Hey, Debbie, you have a question for Jay?
Yes, thank you. Thank you so much for that presentation. I do have a question for you. Are y'all involved somehow with our schools or school districts or any kind of implementation with the schools?
Jay, I can jump into that if you like. Yeah, so that's where it's really exciting. So Healthy Communities has a great relationship with our school district in Lyon and through Eric Schoen with Story. And CHWs are heavily utilized. They're part of the Safe School Professional Network, which is everything from a CHW all the way to a licensed clinical social worker. And so we've really seen how successful this can look. Community health workers, of course, are, have to be trained, and we're, ensure that they don't go outside their scope. But one example is we have the national outcome measures that can be done by a clinical person, but it can also be done by a trained CHW. So the CHW is trained and can do those assessments, and that enables our clinicians to do clinical work rather than doing these surveys or these assessments. Our CHWs have been trained in like check-in, check-out, behavioral supports, signs of suicide for the education, and that follow-up interview for youth who are identified as not meeting that clinical need. They do bounce back, they do set. So there's tier 1, tier 2, and even tier 3 possibilities for those CHWs doing those evidence-based interventions. And then there's, the tier 1 for, referrals as well. So, I always hear Eric Schoen's voice in my head with these, what's possible with community health workers. It doesn't always have to rise to this clinical level. And they're really showing these great efforts, and we're seeing, we're really kind of receiving the benefits of them being placed in the schools and providing those interventions and getting there before the youth, escalates to this higher level. So we're looking at, they're currently using a BH Works system with the goal to bill Medicaid. And that would be under provider type 60 because it's school-based, which would be nice. We're hoping to start dipping our toe into that this year. But you know, we're well on our way and we're excited to see what's happening. So I hope that answered your question.
All right, thank you, Wendy. Thank you for that excellent question, Debbie. Anybody else have any questions for either Jay or Wendy? It looks like there are not. So thank you to all three of you, including Cody, for being available and doing this presentation. It certainly helps us to stay up to speed with where things are at for community health workers. And I will move us on to the next agenda item, and I'll ask if Chair Johnson is able to step back in.
I think I'm back in. Can you hear me okay?
We can. It's all yours.
Wonderful. Apologies, everyone. Clearly, our virtual desktop system is not built for Zoom, but I'm following along via phone. I wanted to, again, to extend my thanks to Jay and Cody and Wendy. And if your time allows, we'd love for you to stay on as subject matter experts. We'll be considering a couple of our community health worker recommendations, and hopeful that we'll be able to hear more from you on that front. But if your time does not allow, I totally understand. With that, I'm going to move, I'm going to postpone. We have agenda item number 5, a presentation on school-based prevention programming. Our presenter is unfortunately not available to be here at this particular meeting today, but hopeful that we can reschedule this presentation at our meeting, ideally next week, if there's still availability and time on the agenda. Ms. Rodriguez, we can work on that offline?
Yes.
Okay, wonderful. So with that, I'm going to move on to agenda item number 6, which is to discuss and revise the remaining 2023 prevention recommendations. As you all will recall, that in addition to the 7 harm reduction recommendations that we workshopped during our August 7th prevention subcommittee meeting, there are 4 prevention subcommittee recommendations from 2023 that will need to be discussed. The following slides, which my Zoom is currently timed out, so I cannot see. The following slides will include the 2023 report recommendations and their corresponding components that we were required to include, including the justification, the action step, the impact, capacity, feasibility, urgency, and impact on racial and health equity. And I believe, if my notes are serving me correctly, that items in red indicate a suggested change or new information that was collected by SEI staff from subcommittee members and subject matter experts for our consideration and discussion today. So as we look through these together, we'll need to determine if we're going to move the recommendation forward as a 2024 recommendation, and then if we'll adopt the revisions. Am I catching everything correctly via phone?
Yes, that's correct.
Okay.
I would just add, yeah, so again, anything in red, it's something that was either emailed to me or was discussed in a previous meeting. So we've tried to compile everything for the subcommittee members' consideration for whether a change should be made or anything like that.
Fantastic. Can we move to recommendation number 1? Hopefully you have that up on the screen.
Yes, I just put the slide on the screen.
Terrific. So as you can see here, this was our the recommendation number 1 from the 2023 recommendations. This was workshopped based on feedback from Senator Doñate and others as we look through updating this particular language. So the section in red was recommended for a workshop here, and opening this up to the subcommittee for additional discussion and consideration.
Hey, Chair Johnson, Eric Schoen for the record. I haven't seen this since the last time we looked at it. And I have to say, I really like this increased specificity that Senator Doñate recommended that we include. I think it makes it a more effective recommendation. So I'm actually getting a little bit excited in seeing these again.
Wonderful. Thank you for that feedback. Any other discussion on this item as amended, or other feedback that the committee would like to provide?
I'm not sure if you're taking input from those not on the subcommittee at this time, but I do see someone has their hand raised. I'm not sure if you're able to see that.
I can't. No, apologies. You'll have to help me out. Sorry, Emma.
Oh, that's okay. We have Elise Monroy with her hand raised.
Yeah. So Elise, who's a member of the ACRN committee, as a subject matter expert, we would take your input on this.
Excellent. Thank you, Chair Johnson. I appreciate the opportunity to give my insights. Elise Monroy Marsala, for the record, I am on the ACRN, and I just wanted to say that as an ACRN member, I appreciate the clarifying language here. One of the things that if you followed our process in this last our last kind of round of recommendations, this recommendation was hard for us because of how it was worded and because of how it came over. So I just appreciate the addition of the language. So I just wanted to say thank you. As like my membership on the AC, as a member of the ACRN, I appreciate the time that you guys took to look over this again. This was a hard recommendation for us. Of course, we support and with the ACRN, we want that funding to be used to support prevention programming. When we received this recommendation, just so everyone is kind of clear, it looked to us like this recommendation was asking us to use ACRN funds to the tune of $24 million. So it was really hard for us to figure out how to like square that. So appreciate that you guys took a second look at this. So thank you.
Thank you, Ms. Monroy Marsala. Any other discussion from the subcommittee or SMEs joining the call today? All right. I believe the plan is that we'll vote on these all together after presenting preliminary input to the larger surge in later September. Ms. Rodriguez, can you confirm that?
So
Okay.
Chair, I believe what the process could be is I'm taking notes on if there's any changes. I didn't hear any objections to this, so I don't know if we need Mr. Feely to weigh in here. Should they be voting individually right now, or should we hold that for the September meeting right before we decide which recommendations to send to the surge in October?
As long as it's on the agenda for possible action today, you can go ahead and do it today, but then there would be no problem with you holding off until a later date to do that as well.
Okay, great. So I think it's up to you, Chair, how you'd like to handle it.
Debbie, go ahead.
Hi, Debbie Nadler for the
Ms. Nadler.
record. Can you hear me?
Yes.
Oh, perfect. So I would like to see us vote on this today. I think we all agreed this was at the top of our list. One of the most important things. I mean, they're all important, but I remember this being at the top of our list, and I think we should vote on it.
All right, wonderful. Well,
today.
if there's agreement then on the amendments to the recommendation, then we can vote on them. And if further discussion is needed, then I'm in favor also of continuing with the notes to discuss at a later meeting and bringing in additional data as needed. So with that, I'll take a motion to approve the recommendation I'm going to call it recommendation 1 as amended, with the additional edits to this particular language from the subcommittee.
I motioned, Debbie Nadler motioned that we do take this recommendation justification.
And
Thanks, Ms. Nadler. Do I have a second?
Eric Schoen, I'll second.
Wonderful. Second from Mr. Schoen. All in favor, say aye.
Aye.
Any opposition to these amendments? And any abstentions? All right, hearing none, we move to adopt recommendation 1 as amended. Let's move next to recommendation number 3, which I'm referring to these as they were in the annual report ranking, not necessarily from our subcommittee rankings, just for folks following along at home. Recommendation number 3 is around expanding Medicaid billing opportunities for prevention services to allow blended and braided funding to facilitate expansion to access to care. Vice Chair Schoen, I know we had an opportunity to, or there was an opportunity to dialogue with staff about this and recommended removing it due to its duplicative nature with recommendation number 8. Is there anything additional that you'd like to add to this?
Only that when we get to item number 8, I think it'll become self-explanatory.
All right, wonderful. Any further discussion from the committee on removing recommendation number 3? All right, hearing none. With that, I'll entertain a motion to approve Vice Chair Schoen's recommendation to remove this as a recommendation for 2024.
This is Debbie Nadler. I agree with Chair Schoen's recommendation to remove this.
I hear a motion from Ms. Nadler. Do I have a second?
This is Eric. I can second.
All right, a second from Vice Chair Schoen. All in favor, say aye.
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 All right. Any opposed? And any abstentions? All right, it sounds like we will be able to remove this recommendation from our 2024 ranking. We're just getting things done today, subcommittee. I love this. We can keep up the good work now that I restarted my Zoom and can follow along at home. Let's move to recommendation number 5. All right, wonderful. Recommendation 5 centers on a bill draft request regarding the set aside of tobacco control and prevention funds from the Fund for Healthy Nevada. We had great presentation from tobacco control program experts across the state to help inform this particular recommendation, background, and justification. SEI staff were able to reach out to the SME that we had present to see if there were any updates or movement on this recommendation, and he informed us that there has not been any movement on this at this time. So the recommendation was to continue with this particular item as it stands with no edits or changes. Ms. Nadler.
I'm pretty sure this is the one I had the question about. I got to figure out how to put this lightly. This was the one where we talked about the marijuana smoking, wasn't it, being added to this as well? And we were going to have somebody do a presentation on the marijuana. Not that tobacco control is not important, because it is, but don't we have funds coming in from the state, or any funds from the tobacco lawsuit as well that can perhaps be used towards this as well?
Yeah. Thank you for your question, Ms. Nadler. I'll let Ms. Rodriguez hop in here in a moment because I know we've been dialoguing about this. So this particular fund does pertain to tobacco control and prevention. So as written, this is hence the recommendation from the committee. We have been working to identify a subject matter expert who can come speak to the cannabis recommendations, and we can add the inclusion of any funds or funds received as a part of that presentation recommendation. The dates that we had for our subcommittee meetings in 2024 have not worked with the subject matter expert at this time, but it's still on. It's still in progress as part of a plan, if that makes sense. Hopefully that answers your question.
It does, but do we have to? Will we be able to add wording to this bill to include the marijuana? I mean, or is this going to go through? I mean, this recommendation, not bill.
I'd be open to hearing from the committee if they would recommend that language change. My personal opinion is to caution against that, just because this particular fund is set up. My understanding of it is set up specifically from the tobacco control and prevention dollars.
Chair Johnson, Eric Schoen.
Go ahead.
Yeah, for the record. So Debbie, my memory is in sync with Chair Johnson's memory. Every time we've had somebody present on this, they have recommended staying narrowly focused on tobacco for this particular recommendation, which, to go back to something you said earlier, is not to say that addressing the use of marijuana is not important, but I think that would be a separate recommendation and not included in this. I think if we include it in this, we run the risk of a recommendation that can't really go anywhere because it becomes a little bit too burdensome.
And I understand exactly what you're saying, but we do have the words smoke-free coalition, and wouldn't that include marijuana? I mean, people smoke marijuana, I guess. I'm not in the scene, I don't know, but and also, again, do we have to use all the opioid lawsuit money on this? Can some of this not be pulled from the tobacco lawsuit money, or is some of it being pulled from that money?
Great question, Ms. Nadler. I'll do my best to answer. So the Fund for Healthy Nevada is a separate fund from the Fund for Resilient Nevada. They sound similar in my head. But the Fund for Healthy Nevada, my understanding, was created from the tobacco settlement dollars. So there's a whole separate set of legislative guidance for the expenditures from that particular fund, separate from the Fund for Resilient Nevada, which governs the opioid settlement funding. My recommendation to this committee would be that if there's a particular recommendation around cannabis or marijuana expenditure, that it be a separate recommendation considered by the committee, not intertwined with this one at this time.
Okay, can we definitely get that moving? We have so many, it's a gateway drug. It's the kickoff drug, and there are so many kids in our state using it, suffering mental health disorders from it. I have numbers all over. I mean, I think it's the utmost importance, but I mean, if we have to do it separate to get this passed, I understand. I just think it's so important.
Chair,
go ahead, Vice Chair Schoen.
Yeah, so the other reason I think it's really important for this to be focused on tobacco, which I thought from the beginning, is that so frequently when tobacco is lumped in with other drugs, it's the other drugs that get the attention and get the focus. And the tobacco prevention has never really been properly funded on its own, nor historically been given a chance to really develop strategies that help to address just the use of tobacco. And so I think this is a unique opportunity for us to say, hey, the use of all drugs concerns us, including the use of tobacco. And we want this to be considered on its own merits and for strategies to be specifically developed for reducing the use of tobacco and not have that possibly be sidetracked by adding in another drug that might take up more of the attention or the focus.
Okay,
Yeah.
and just to clarify, so some of the money would be coming from the opioid lawsuit money, and some will be coming from the other money, the tobacco money, unless I'm confused, is that correct?
No, as written, this recommendation centers on the Fund for Healthy Nevada, does not include the Fund for Resilient Nevada funds.
Gotcha. Okay, thank you. Sorry. Got it.
Chair Johnson, can I make a remark?
Yes, please.
I think it's Reno.
Oh, I'm gonna mute somebody. Okay, so Emma Rodriguez, for the record, the action step that was included in last year's annual report was identifying funding sources alternative to the FRN that can support these statewide programs. So I'm not sure if that needs to change. And then I just wanted to go back to Ms. Nadler's point about bringing forth a new recommendation specific to cannabis. We would need a subcommittee member to submit language and like an actual recommendation on that. So we don't currently have that. So that's something that we would need to get soon. Our next meeting is next week. So I just wanted to point that out.
Thank you, Ms. Rodriguez. And we can resend out the link to submit recommendations to the committee at the conclusion of this meeting.
Perfect. Thank you.
So as this stands as written, I am happy to move forward with it. I don't know that did we vote on it? I'm bad at this part. To adopt as written for our 2024 recommendations.
Chair
Vice
Johnson.
Chair Schoen.
Yeah, Chair Johnson, I would make that motion.
Do I have a second from a committee member? As the chair, can I second this motion? Sounds like perhaps we need some additional discussion on this item. Dag Feely, can I take this off of, can I let the motion die?
Yeah, you can let the motion die. Maybe, I mean, if so many people are against it, maybe somebody wants to make an alternate.
Yeah, Chair Johnson,
motion.
I'll withdraw my motion.
Thank you. We can discuss this at our subcommittee meeting next week if there's additional opportunity and revisit again. All right, let's move on to our unranked recommendation, if that's all right, in the interest of time. Wonderful. So one of the items that was unranked from the 2023 recommendations was related to a data dashboard on creating a way to report on alcohol, tobacco, and cannabis outlet density. Staff has been made aware that the response subcommittee is considering 2 recommendations related to data collection and reporting, and they are expected to include language related to outlet density. So at this juncture, with that support from the response subcommittee, we could remove this recommendation and lend our support behind the 2024 recommendation from the response subcommittee. Any discussion or thoughts from the committee on that strategy?
That sounds good to me. Eric Schoen for the record.
Wonderful.
Sounds good to me too. Debbie Nadler for the record.
All right, fantastic. Hearing the discussion from the subcommittee, I'll entertain a motion to remove this recommendation from the prevention subcommittee as written and include support for the response subcommittee's recommendation related to data collection and reporting.
Debbie Nadler for the record. I make a motion. We remove it.
Thanks, Ms. Nadler.
Eric Schoen for the record. I'll second that.
All right, thank you, Mr. Schoen. All in favor say aye.
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 Any opposed? And any abstentions? All right, motion carries. So we can remove this with our support to the response subcommittee as they entertain the important focus on data collection. Additional prevention recommendations that we've discussed at meetings. I know Ms. Nadler, I was heard through staff that you've been gathering some information on the school ID card implementation in schools. I was wondering if you'd like to discuss more about what you found.
Yeah, thank you so much. And thank you for sending me the information. I see we had a bill passed, and correct me if I'm wrong, in 2022, is that correct, Jessica? That mandated on the back of all our school cards that there's a safe voice. There was actually 3 things, and a 988 safe voice and suicide hotline that was supposed to be on the back of all our student ID cards. It's not being done. It's being done in some of the schools and not all. I took a survey in a group I'm in with a group of 100,000 parents in our state, and I had them all look at the back of their student ID cards. Half of the kids had it, half did not. So I called CCSD and I spoke with, I'm sorry, I'm just trying to get to, let me just get to my notes here. I spoke with the executive assistants for operational services, who told me it was supposed to be done. They were aware of the bill. They were supposed to be doing it this year, but she had to transfer me to another department. So I spoke to the education service department and found out that what happened this year was that different schools have different photography vendors. So some of the photography vendors didn't get the memo to put the information on the back. So then I was told to call the government relations department, which I left a message with the Dr. Keating, who is in charge of this, because what they were going to do is print out stickers that have all the information to put on the back of the student ID cards. However, there's not really a middle person, so to speak, or somebody to actually enforce and see what's exactly going on, because I can tell you I was transferred to 6 different departments. What I did find out was, and I did ask them, and they're printing out the stickers right now. They were, as of last week, printing out the stickers for the kids who didn't get them. I asked if they were going to email all the principals and everybody to let them know to put the stickers on the back of the cards. Bottom line, I was never called back by the doctor who was in charge of the government part of the CCSD to see how they were going to keep up with how the principals were enforcing that those stickers be put on the back of the cards. But I also found out if a student loses their card, it's not reprinted, even if it was printed on the first time on the back, all the information. So I'm not sure what we can do or how, or if there needs to be a person in charge of implementing all this, but I would love to say I would go to every school and talk to every principal, but that's not my job. We need somebody who I don't know if we vote on a middle person to do this, or I don't know how to make sure it's being done, but it's not.
Yeah, thank you, Ms. Nadler, for sharing all of your tenacity behind the scenes to follow up on the presentation of the ID recommendations that we discussed at our last meeting. I'm hoping perhaps Member Nichols can weigh in on some recommendations for who might be in charge of the implementation of this particular law, or any other SMEs on the call who maybe collaborate with school administration could help us understand a little bit better about what a recommendation might look like around how to improve the reach of this particular law. I'll give folks a moment to unmute. All right, so it sounds like maybe the next step is to understand a little bit more about the barriers to implementation of this particular law. Ms. Nadler, to your point, I don't know that that this committee has the power to appoint somebody in terms of oversight for implementation, but I do think there's opportunity to make a recommendation about the consistency of implementation, or to a particular board or entity that might be able to follow up on your question.
Yeah, I mean, that would be great if we could. I'm not a wordsmith. Y'all are the wordsmith. But I can tell you that hundreds of parents, when I wrote that, just taking a poll from everybody, were like, oh my God, I would love this. This is an awesome idea. Because the parents, the students are wearing their cards now. That they are doing. And the parents like to see the back of the card too, if they need help, or if they want information. Perhaps we could make a recommendation somehow that we put somebody in charge of implementing this, following up with the principals, following up with the different school systems in the CCFD. I don't know the proper wording to do this. It's really in me.
Yeah,
I think it's very important.
Yeah, Ms. Nadler, and what I hear you asking about is the consistency of implementation. So while I know your phone calls were within the Clark County School District, perhaps ensuring the consistent implementation across the state would be of importance as well, and of concern to this particular committee.
Yes.
Just wondering if Member Nichols has been able to unmute. I'll pause just for another moment in case he's available. All right, perhaps we can follow up with Member Nichols to help us identify who could be a good candidate, but and maybe Vice Chair Schoen, I know that you are an excellent, I see Dr. Kearns from our SURG response subcommittee, and SURG in general is on. Dr. Kearns.
Thank you, Chair Johnson. I just had a couple of thoughts I wanted to offer. We had a similar recommendation about some legislation that was passed with the coroner and MEs, and our suggestion was that perhaps the LCD conduct an audit on that legislation. And the other thing is, if you're looking statewide, perhaps engaging the Nevada Department of Education, and they could also potentially look at some sort of audit or implementation.
That's an excellent suggestion. Thank you so much, Dr. Kearns, for hopping online. So it sounds like there are two opportunities here, Ms. Rodriguez. One might be to recommend the Legislative Council Bureau conduct an audit on the implementation of, I'm going to miss the bill number related to putting the crisis lines on the back of school IDs, better understand implementation. And then a request to staff to reach out to the Department of Education to understand the strategy for statewide implementation of this particular legislation and the communication to the various school districts, and the oversight is what I'm hearing from our committee member too. Ms. Nadler, is there anything else you would add to that? Hopefully my internet didn't cut out.
No, we can hear you.
Okay, terrific.
I would somehow like, is there some way we can do something with the elementary school IDs as well? I mean, I don't know if this would tie into it, but the middle school and the high school kids are all wearing their student ID cards around their neck, right? The elementary school kids are not. I get some portion of why they're not, but then I start having all these thoughts in my head of, God forbid, you know, the shootings and whatever. I just think the elementary school kids should be wearing their IDs if they have them, or they should have IDs around their necks as well. I mean, in 4th and 5th grade, they know so much. They know what we knew in 7th and 8th grade now. So somehow if we can incorporate it in, you know, or elementary school as well.
Thanks, Ms. Nadler. So I do think that would likely be a third separate recommendation, and as perhaps amending the bill as written to include elementary students. It's not an area of expertise for me, so I don't know how the rest of the committee feels. I'd like to perhaps get the Department of Education to weigh in on the pros and cons of such a type recommendation, such as that. I'm seeing Mr. Schoen on video give a thumbs up, just to ensure that there aren't any unintended consequences with a recommendation like that, if that serves the committee for follow-up.
I kind of think we need to in order to do our due diligence is give the Department of Education a chance to provide some feedback and guidance.
Yeah, that sounds great.
Yeah,
It may be
yeah.
short notice to have an SME step in next week, Ms. Rodriguez, so we can try to identify someone potentially that could help guide us on this. Perhaps someone is on the call today and could follow up afterwards with an opportunity to even just speak at our meeting on the 7th. All right. Thank you for that discussion. Any additional recommendations and language would need to be submitted by, sorry, I said September 7th. I meant to say September 4th. Would need to be submitted and ready for the subcommittee meeting next week on the 4th, so that we have time to vet it on this committee, present it at the SURG meeting in September, and then make any final edits before our meeting before the end of the year. Are there any other discussions or recommendations at this time from the committee? All right. Hearing none at this moment. Ms. Rodriguez, I wanted to do a time check with you to see if we, given the changes to our agenda today, have time for agenda item number 7.
Yeah, Chair Johnson, I think we do, since that one presentation was rescheduled. And then maybe we should just leave 5 minutes at the end for the last couple of agenda items, so I can let you know if we get to around 3:25, if we're not done with agenda item 7 yet, maybe we can continue with that at the next meeting if we don't get through it all.
Thank you for the guidance on time. I really value and respect the committee and the folks who've joined in attendance today. So with that, let's move to agenda item number 7, which is a review and discussion of the revised 2023 harm reduction recommendations that this committee has also been tasked with. As just some guidance here, at our August 7th subcommittee meeting, we discussed and workshopped our specific 2023 harm reduction recommendations. And these slides again helpfully outline items in red indicating change or new information collected by staff from subcommittee members or subject matter experts for committee recommendations. So once again, I think if there's consensus, we can adopt any amended language or changed language. And if we need items for further discussion, we can move them to our agenda or our meeting next week to give staff and others time to gather any additional information. All right, let's dive into recommendation number 7 as referenced in the report. So we had a long discussion about this particular recommendation around baseline level of identification and opioid reversal medication, like a stabilized source. I believe the supporting language here goes into how a lot of the naloxone or opioid overdose reversal medication is grant funded. And so I proposed this particular language back to staff for discussion today. This is focused on developing an annual or biannual saturation and distribution plan, being regularly revisited and updated, and then requesting that DHHS utilize opioid settlement dollars to designate this baseline level of identification and overdose reversal medication funding for the next 10 years in Nevada based on this plan.
Debbie Nadler for the record. Great. I like this.
Thank you for your feedback, Ms. Nadler. Any other discussion from the committee members?
Yeah, Chair Johnson, Eric Schoen for the record. I think we're missing just a word or two. So towards the end, we mentioned to create a stable, sustainable overdose reversal medication. I think we want to say to create a supply of stable, sustainable overdose reversal medication throughout the state.
Yes, you're correct. And this is why you're the wordsmith. here.
I'm not sure. Okay.
Yeah, I'm also wondering, yeah, thanks, Ms. Rodriguez, for throwing this into edit mode. I'd also potentially recommend omitting the which should be regularly revisited and updated if we're recommending an annual or biannual saturation and distribution plan.
Good point.
Since we're already recommending the frequency of updates.
Good point.
And this, I believe that there is a saturation plan that already exists, but I don't know that there's a distribution plan based on that saturation plan. I don't know if there are any SMEs who work specifically on this on the call that could help inform this recommendation at this time. All right, any further discussion from the committee on this particular item? With that, I'll entertain a motion to approve the recommendation number 7 as amended here in the meeting today in red and purple.
Debbie Nadler, for the record, I make a recommendation that we approve the red and purple amendments.
And
Thank you, Ms. Nadler. Do I have a second?
Eric Schoen, for the record, I'll second.
Thank you, Mr. Schoen. All in favor, say aye.
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 Aye. Any opposition? And any abstentions? Hearing none, this moves forward as amended. Thank you, Ms. Rodriguez, for your speedy typing on that end, on the back end. With that, we'll move on to recommendation number 8. Vice Chair Schoen, I know these, this was some of your language based on conversation. I was going to turn the floor over to you to walk us through your recommendation here.
Sure, I appreciate that. So Eric Schoen, for the record, and memory has it that we wanted to be more specific on this. And in that conversation, and I'm referring to our last meeting that we had, Senator Doniate indicated, I think there was some movement afoot about within the state amendment plan. This is what I was hoping to get some more feedback, if he's currently available, to benchmark this to 10%, if not more, just to show that we're in support of that. So Senator Doniate, are you on and available to provide input?
Picture shown he was on. I saw you turn this camera off, so he might have had to step away briefly.
I see that as well. Perhaps Chair Johnson, we can come back to this one in case he's available in a moment.
Yeah, absolutely. Any other discussion from other committee members in the interim of the changes recommended here? I appreciate the increase of specificity. So thank you for your efforts on that and background work.
You are welcome.
Right. In the interest of time, I am going to hold recommendation 8 and the edits for now. And if Senator Doniate is available, maybe her steps back in, we can revisit number 8. Let's move to recommendation number 10. In the original recommendation was this is related to smoking supplies. And we had a presentation from Colorado at our last meeting. And so based on that, I recommended the proposed following language, which was to create a bill draft request at the legislature to change the Nevada paraphernalia definition as it relates to smoking supplies using either Maine, which we had considered before, or Colorado as examples, with links to the specific examples from these particular justifications. We are still awaiting comment and feedback per the discussion of this committee from Nevada Sheriffs and Chiefs Association, the Nevada District Attorneys Association, and hopefully we can connect with the public defenders as well for input on this particular recommendation. So open to any input or discussion with where we're at so far from the committee, but I would like to reserve moving it forward until next meeting, just in case we're able to get that additional input.
Chair Johnson, this is Eric Schoen for the record. I would agree with that recommendation of yours to postpone making any determination on this until next week, and to give those other groups that you just mentioned an opportunity to provide input.
All right, fantastic. Thank you, Vice Chair Schoen. I'm hoping, Senator Donyate, if you're available to comment on recommendation 8, we can move back there if that's all right. I think Mr. Schoen had a quick question for you.
Yeah, so Senator Donyate, are you available by chance?
Yes, please proceed.
Great. So this was what I tried to craft out of our conversation from our last prevention subcommittee meeting, and I want to know if I even got close to what you were kind of recommending. If not, how you might recommend changing this. Specifically the part in red.
And if you're speaking, you may be on mute. Sorry.
Thank you, Chair. The first part of it looks fine. I would ask for specificity on the increase in number of hours that can be billed per month. Probably that is a part that you have to set a threshold, but the first part makes sense.
So when you say the first part, 10% for the current rates, but then we also need to have specificity for the number of hours that we want to.
Correct.
Okay. So then, thank you. I appreciate that. I'm relieved I got this close, actually. So if Jay and or Wendy is on the call, and Chair Johnson, if you don't mind me asking whether one or both of them could weigh in on if they think an increase in the number of hours is warranted, and if so, what that number should be.
Yeah, I see Wendy is still available, but it does look like maybe Jay had to step out. I don't know if, as an SME, Wendy, if you're able to weigh in on this. Sorry to put you on the spot. If you have any
that's
input
that's
or
okay.
insight.
This is Wendy. I am not familiar with what the current number of hours is. Eric, do you?
I thought I heard Jay say it was 12 hours a month.
That's pretty limited. So I would see, especially as the CHWs are being used so readily, 12 hours per month. I would see at minimum 20 would be a great improvement.
So thank you, I appreciate that, Wendy. I was thinking maybe we could just put double the number of hours per patient, per client, whatever the correct verbiage is on that.
Client, patient, individual.
Thank you, Mr. Schoen, and thank you, Ms. Rodriguez, for editing on the fly here.
Chair Schoen, does that look right, or did you want to specifically put a number?
No, I mean, I think it's implied. I think we're good with that.
And did you also want to add that that's per client or per patient?
Well, I think that's also
Or was
implied.
it-
I mean, if somebody wiser than me thinks we should, but I think it's implied. I mean, 10% current rates, that's per client. I think it's implied, but if we need to be more specific, if there's somebody smarter than me on the call, please let us know.
Senator Nyate, I see you have your hand up. Go ahead.
Thank you, Chair. The only so now that I'm thinking more through this, what I would recommend is this recommendation should be changed to require the state Office of Medicaid to provide a state plan amendment. And rather than doing 10%, I would argue that it would make sense probably to meet the national average of what CHWs and professional workers get reimbursed for, and probably that would the wording would also reiterate back to the number of hours that are billed based on national averages or what the standard is. And the reason for that is I think there's a question of when you bill per patient, specifically and this is more so in behavioral health, you need to quantify what the visitation looks like. And when you open up the susceptibility of being able to bill more, that could also lead to fraudulent activities. And so there needs to be a connotation of, are we reaching what's best practices or what is set for federally for the specific industry? That's the only thing that I would just mention. So I don't know if Eric has a response to that, but traditionally that's the way that we look at meeting reimbursement or expanding reimbursement in specifically in behavioral health.
I appreciate that because I think, and I like that recommended change, because in my mind, 10% is not enough. And if we benchmark it to a national average, that's actually more in line with where I think at a personal level, after looking at everything, the reimbursement rates for community health workers and peers needs to move towards. So yeah, some sort of benchmark national average would be a good point of comparison.
So then you take out the by at least 10% language to align, and then to align with the national average. Yeah. And take out the rest of the language as well because of the other statement. Does that look correct as recommended by the committee?
The billing standards in terms of what can be billed per patient should follow the same language of following national standards.
So requesting rates and billing standards for CHW and peers be aligned with the national average or national standards?
That's correct. That would be my recommendation.
So requesting rates and billing standards.
So, Chair, and the reason why I'm mentioning this is, so for example, when the CMS was determining options for how they were going to reimburse for another type of service, the most frequent one that we just did was telemedicine. The state followed what CMS was reimbursing for, and it set the same threshold. And so essentially that's kind of what we need to follow is what is the baseline of where we need to go for reimbursement rates, and then whatever the billing standards are is also what we need to follow based on CMS and what other states are doing.
Yeah, thank you for helping us wordsmith this to be more aligned with a solid recommendation.
Okay. Chair Johnson.
Is it too? Go ahead, Vice Chair Sean.
Can we just read this out loud to make sure that it reads the way that we want it to?
Take it away.
Okay. Require the State Office of Medicaid to develop a state plan amendment to implement changes to support the recommendation. I think requesting rates and billing standards for CHWs and peers be increased to align with the national average. Does that sound close to what you think the ballpark we need to be in, Senator Doniate?
Yeah, that's fine with me. I mean, it gives the motive and the flexibility to the state Medicaid office to at least align it towards what's happening nationally. So I think that's fine.
Okay.
Should it read national average or slash standards? Or is national average appropriate in this juncture? Don't want to wordsmith, but if we're wordsmithing.
If there was a standard, it would be based on CMS. So I mean, that would be where I would point towards.
So how about with the national average and CMS standard?
There you go, CMS standards. Yeah, that's good.
Wonderful. Thank you both for your expertise and work. What was that, Ms. Rodriguez? I'm sorry.
Oh, I was just noting that we are about 5 minutes out from our end time. If you want to continue with this agenda item for next week's meeting, or if you want to keep going, we can push the other agenda item to next week's meeting.
I'm happy to, if we can take a brief moment and see if there's a consensus to vote on this particular wording changes for agenda item 8, and then if we can include starting at recommendation 13 in next week's meeting. I'd like to move on to just ensure that we have an opportunity to discuss and provide guidance on the voting and ranking of the recommendations at this meeting for staff, if that's all right with the committee.
Sounds good to me. Eric Schoen for the record.
All right. So with that guidance, I'll entertain a motion to amend agenda item number 8 as workshopped here today with the text on screen in purple and red below for the committee.
So moved. This is Eric for the record.
All right. Do I have a second?
Second, Debbie Nadler for the record.
All right. Thank you. All in favor, say aye.
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 Any opposed? And any abstentions? Motion carries. Well, with the verbiage as amended.
Chair Johnson, can I just
go ahead.
I just
Ms.
wanted to
Rodriguez.
know if subcommittee members have any additional supporting information, such as what the national average and CMS standards are. We can include that in the report, and it would likely help bolster the recommendations. So if folks are able to research that and send that to me, I'd be happy to include that.
Thank you, Ms. Rodriguez. I encourage the committee members to help support staff in ensuring the robustness of this recommendation for our SURG subcommittee meeting. Thank you. We're going to move to agenda item number 8 so that we can discuss the approach to the ranking process. And in our meeting next week, we'll have an opportunity to discuss the rest of these. Thank you to Ms. Rodriguez and staff for preparing these meetings. Ms. Rodriguez, would you like to share the recommended options for ranking with the committee?
Yes, so I'll do this really quickly because I know we're approaching the end of our time. So basically all subcommittees have been asked just to weigh in on how they think the recommendations should be ranked in the final report, in the annual report. And all of your feedback will go to Attorney General Ford, so he can kind of make a suggestion for how it should be done in the 2024 report. So just you'll see on the screen in 2022, the SURG did a weighted ranking with the recommendations with multiple members ranking it as their top recommendation. They received, those recs received a higher aggregate score. Then last year we ranked the full slate of preliminary recommendations in October and then again in December. And that reflected the relative importance of the different recommendations. And then there's another option this year where the SURG could rank recommendations by subcommittee topic area. So we just wanted to make sure all subcommittee members had an opportunity to weigh in with how they think it would be best to be included in the annual report. So I can share what the other subcommittees discussed if you'd like that, or if anybody wants to just give their opinions now, I think that works too.
Yeah, thank you. Open to discussion. Vice Chair Schoen, what are your thoughts? Do you have a preference?
Just a quick question for Emma. Hey, Emma, this last option, does that mean we would rank like the top 5 for prevention and the top 5 for treatment, and the top 5 for harm reduction? And so each of those would kind of have a chance to have a top billing, and they wouldn't be sort of included with all the others?
So Vice Chair Schoen, I don't know that there would be a limit on the number. I think it would just be ranked within, so like prevention, and that's a good question. I don't know if the harm reduction ones would be separated out from prevention or if they'd all be included, but I think the way that this option would work is the whole SURG would rank the recommendations as they came out of the subcommittee, and then they would be included in the report under the subcommittee in a specific order as voted on by the full SURG.
So yeah, Eric Schoen, thank you for that. Eric Schoen, for the record, I kind of like that idea, because then the prevention ideas aren't competing, for example, with the treatment ideas and vice versa. And it gives all of those really important recommendations a chance to, I think, see the light of day. So I kind of like that.
I agree, Debbie Nadler, for the record, absolutely.
Thank you, Ms. Nadler and Mr. Schoen. Any additional discussion on this topic? Well, I know that there was some confusion in the technology used for the 2023 process. I do think that having one clear list of recommendations was more helpful than having 2 lists in the report, where one was just in the order that they were presented and then one was weighted. So I would opt for not the 2022 method in favor of 2023 or an alternate strategy. Any further discussion on agenda item 8? All right, hearing none, we can move to agenda item number 9. I know we're a few minutes over time. Agenda item 9 is upcoming prevention subcommittee meetings and next steps. So as we mentioned, the September 4th meeting will be our last committee meeting before the full SURG. So we will be focusing on finalizing the recommendations that we didn't get a chance to finalize in today's meeting. And then we'll meet again on November 6th to consider any feedback we received at the October meeting and finalize the recommendations. So this is a brief reminder. If you have any recommendations that you would like the committee to consider, we will need the final language by the September 4th meeting in order to discuss them in advance of the SURG meeting in October. Any questions on this process? All right, hearing none, we'll move to our agenda item number 10, which is our final period of public comment. Again, public comment will be received on Zoom by raising your hand or unmuting yourself. Emma read the telephone number earlier, so I think that we're covered on that front. Anything else that we need, Emma, before I open this up for public comment? All right. Do we have anybody for public comment?
Chair Johnson, I do not see anybody wishing to provide public comment at this time.
All right. We'll go ahead and close the period of public comment and move to agenda item number 11, which is adjournment. I kept you all 4 minutes over today, and I just wanted to say a big thank you to Margaret from SEI. It is her last meeting with our SURG prevention subcommittee and does incredible work in the background to keep us going along with the rest of the SEI team. Best of luck on your new adventure, Margaret. Have been glad to have you as staff to our committee.
Thank you so much. I'm gonna genuinely miss supporting this subcommittee. Thank you.
Grateful for your support. Have a good rest of your week, everyone. Thanks for the work you do. Take care.
All right, take care, everybody.
Thank you. Take care.